Hello.
Hi, everyone. Welcome.
Good evening. We're here in Michigan Center for Regenerative Medicine. Dr. John Santa Ana.
Rob Farhat.
Tom Nabity. Thanks for joining us tonight, everyone.
So our topic for tonight is PRP and what makes it different, what makes it special. Why is there are different types of PRP and what makes one better than the other? All right. So this topic kind of started because I've had questions from patients because we do a lot of regenerative medicine here in this area. PRP is one of the options that we provide. And patients would ask us, what makes your PRP different than other people's, right? Because now PRP is getting more popular. A lot more practices are offering PRP procedures. So I figured it'd be a good time to discuss what exactly is PRP, how it's made, and what quantifies a good PRP for good outcomes.
So you can see we've changed our venue. We're not in the procedure room tonight. We decided we go from our regenerative lab, and we'll explain the equipment that's in the background here and how we use it to highly concentrate our blood product to make PRP, and then how to count it to make sure what we want to be in our PRP is in fact in there before we re-inject it.
Yeah, so first, I kind of want to say not all PRP is the same, right? Like not all physicians are the same. So when you read studies and you see these different things that are posted, it's not necessarily all the same. And I had to learn that myself. I started out with what we call a tabletop product, which is a machine that essentially does all the work for you. There's really no one determining whether or not this product is appropriate. And that's how most folks around this area are actually providing this treatment. The difference, as Dr. Nabity just mentioned, we have a lab. We're in our lab here. We have a lab technician that actually is able to identify the cells we want and is looking at the sample that we drew versus a machine that kind of just spins on its own at the rate it's set at and hope for the best. So I think that's the first thing we have to identify, is that not all treatments are the same. Just because they're labeled the same doesn't mean they're all the same.
Yeah. And like Dr. Farhat said, so PRP is fairly easy to make. All you need is blood, and then you need a centrifuge to spin it around in order to separate the different components of the blood. And you take out that plasma portion of that sample, and that's PRP. The question now is how much of that platelet-rich plasma is actually good PRP, and how many platelets are in there? What's the dose of that injectate, and is it going to be enough for you to heal the issue or the tissue that you're trying to fix?
And that's still a question that, if anybody tells you they know the answer to, I'd probably, ask for a second opinion. That's something we're actively involved in, working with our societies, tracking our outcomes, and counting our cells, so that we can try to hopefully someday not dial in what is that magic window. In the pharmaceutical world, it's called the therapeutic window. We know that most drugs have to have a minimum dose in order to have any kind of effect, but that more isn't always better, and that you can take too much of a drug and have major side effects. So what's that window where you've crossed the line, where you've used just enough of the medicine so that it can work, but not too much of the medicine so that you get side effects? We're still in that process in data collection with the regenerative medicine space. I believe there is likely a high end where too much might not be good. We were just talking about that before. But that window is likely very, very wide. It's a very big window where as we're doing what we can do right now with the FDA's guidance on these procedures, what's called minimal manipulation. If we take your cells out, minimally manipulate them, and then re-inject at high concentrations, I don't believe we can get to a level that's going to be too hard to do any damage to you. So in my head, or at least in my practice, I'm in the camp that more is better. And the higher I can get our tech to concentrate your cells, I think it's going to drive our outcomes even better.
Yeah, so we look at these particular models. We have a centrifuge here, this tabletop centrifuge here, compared to the big centrifuge directly behind me. So this essentially has a setting. You put it in the machine, it spins the blood, it separates out the three components, and there's a system which makes it easier for a user to utilize. You don't have to be a medical technologist to use this particular product. So it's great for convenience. It's very quick to utilize. Usually most of the spins take a few minutes at most. So the whole thing start to finish, drawing your blood, spinning it even a couple times takes maybe 15, 20 minutes. Here we have a different approach. We have a lab technician that draws your blood with the appropriate gauge needle, make sure we're not breaking any of the cells. Then we concentrate it, but before we concentrate, actually measure it. What's in the blood we took? So we have a baseline to go off of. Then we concentrate it. Then our lab technician does the pipetting behind us here in this corner. So she's actually looking at this sample to try to get as many cells as possible, concentrating it down, and then measuring it again to see what we got. So normally we want to concentrate as much as we can. So 18, 20 times as much as we can. We're getting cell counts that are literally in the billions. And folks sort of in my age group need that sort of concentration to make an efficacious dose. Here, where we have this tabletop, sometimes you'll get an adequate sample, but sometimes you're only concentrating the cells by maybe 7 to 8 times their concentration, where you have enough cells to maybe make a difference, but maybe not a great difference. And I think that's the difference of what is around the area versus what our practice does. And that's sort of one time, one of the reps referred to our practice as the Ferrari dealership in PRP and orthobiologics. And I kind of like that, So we don't really want to compromise our quality and our outcome because somebody else is doing something else that isn't as good.
Yeah. So this tabletop centrifuge is probably what you would see in 90% of people that would say that they produce PRP. So there's the easiness. It's fairly cheap. It's really easy to do. You essentially put blood in a centrifuge, you turn a couple of knobs, and then PRP comes out, and then you use that. The downside to it is because it is so simple, there's really not a lot of variability control you have on there. So one is you can't control how much PRP you get back because it's only a finite amount of volume that this machine will be able to tolerate. So you can only get so much concentration of that PRP back when you do it. Can you add more blood on there? Yeah, but it's probably you're gonna have to spin it maybe a few more times or have different batches in order to create whatever volume you need. And depending on the structure you're trying to inject, let's say a hip, which requires a lot of volume, or a knee that requires a lot of volume, or if you're going to hit multiple areas, you're going to need a lot of volume. And this machine is just not going to give you that volume that you need.
So we brought it out as a sample. I mean, you can see the size of the machine. It comes with kits that you fill with blood, and then you use a syringe to separate. There's a little filter in there that allows you to filter off the platelet poor plasma and the red blood cells from the platelet-rich plasma. It's a self-contained unit so that it remains sterile. Or you can use a larger centrifuge like what's behind Dr. Farhat here. And just by seeing the difference in the size of the centrifuge, this one will take up to 60 milliliters of blood. This one will take up to 180. So just by virtue of volume of blood that we can process, we're already getting 3 times as many platelets. There's 3 times as many platelets in 180 cc's of blood than there are in 60. And then when you separate those cells by centrifuging them, the lightweight stuff goes to the top, the heavy stuff goes to the bottom. You can use this canister to separate those two, or we can use micropipettes under a vented hood so it stays sterile. And we can dial in exactly how concentrated we want to get those platelets. So best case scenario, we've done testing on the various different machines. This is a very good tabletop centrifuge. If anybody's looking to get started and needs a cheaper
better ones
way to get in, this is one of them that we would recommend. And it'll get you 6 to 8-fold increases in your platelet count versus our process will get you 20 to 25-fold increases. So There's a larger number of blood at a higher concentration. Typically, the final volumes of platelets in this is in the 1 to 2 billion category, whereas we're getting into the 10 to 15 billion.
Right.
It's just a larger volume of blood and a larger concentration. There's not a whole lot of magical science that's happening, but it's heavier equipment. It's more expensive equipment. You have to train a tech appropriately how to do it. So it's a higher barrier of entry that we've fortunately crossed, and now have what we still believe to be the best product in the market as far as PRP goes. We can't take credit for that process. The lab we've partnered with are the ones that developed all these standing operating procedures for how fast to spin the centrifuges, how to train the techs, how far to go into the Buffy coat, and that company's name is Grayledge, and we certainly owe them a lot of gratitude for providing us with that science so that our patients can get these incredible outcomes. We started with tabletop centrifuges and we got outcomes. It's not like people didn't get better. The 3 variables to getting a good outcome: patient selection and diagnostic skill as a clinician, making sure you're treating the right problem. How good are you at placing a needle in the right target that you've identified? Those skills we've honed in our PM&R and our pain management training. And what's changed between when we first started and now is, our skills have probably gotten a little better as we've done more of these, but not dramatically, I wouldn't say. But what we're injecting has gotten a lot better. We've moved from the tabletops to the lab, and our outcomes have gone up. And we use a registry. We can validate that statement with real live statistics, and in the process of publication. So hopefully within this year, I know you're presenting at one of our major conferences some of our outcomes, and hopefully within the next year we'll have some publications to share with you as well.
Yeah, and like Dr. Nabity said, Dr. Farhat said, so we invested in all of this equipment and partnered with a lab like Grayledge because we want to do this full time and offer patients the best orthobiologic that we can and give patients the best chance to heal. We decided to make that decision. We are not doing this as a side gig or as a part-time addition to what we do. This is what we do. We are the Michigan Center for Regenerative Medicine, and then this is why we do things the right way.
Exactly.
Yeah, we really built the practice around what we would want for ourselves, what we want for our loved ones, what we want for our patients, and that's the best. So if you're looking for the best orthobiologic clinic, certainly in Southeast Michigan, would highly encourage you to give us a call and see if that's something we can help with.
All right.
We got a lot of questions coming in. Maybe we'll keep some time for questions. I know Dr. Farhat had some to begin with, and then maybe we can try to read off the question panel.
All right. So first question is from Scott. He's asking, have any of you doctors used PRP for any ailments?
All of the above, yeah.
I'm the only one that hasn't tried it yet. So, but both of these guys have tried it several times for a variety of issues, and every time they tell me it works great. So when I have an issue, I will use it.
So my most recent was a lateral biceps tendonitis. I think I just got my 3-month questionnaire text. Dr. Santana injected it, and happy to report I'm pain-free, able to play tennis, and do all the things that were giving me problems in the gym without pain. I've treated Dr. Santana's injected my lumbar discs, my Achilles tendon, my lateral epicondyle.
He's the poster child,
right? I think that might be about it. So, but it's worked every time for me. So I'm a firm believer in it.
Next question is, what is the main reason to get PRP?
Well, the main reason, realistically, is if you're looking for an alternative treatment that is not a standard of care. So right now, the standard of care is for these musculoskeletal issues. We're talking about these orthopedic type problems: shoulder, hip, knee, back, etc. So our options for the traditional treatment is limited. It's based on what the insurance will cover, what you're willing to do, etc. So when those options run out, we don't have any other options, or people don't even want to consider those options. They don't want steroid injections. They don't want this or that because of the long-term side effects. They don't want surgery. So we're using PRP here at our location mainly for musculoskeletal issues, non-surgical orthopedic injuries, and we're also using some alternative treatments like hair, sexual dysfunction, things like that. But our main focus are the non-surgical orthopedic reasons. So hip arthritis, degenerative disc disease, knee meniscal tears, Achilles tendonitis, on and on. So any of those orthopedic injuries.
Another question is, do you recommend to have an MRI prior to the office visit?
I found this on
It helps. There are indications where MRIs are necessary. They're always helpful. More information and more imaging can guide us, but oftentimes they're not necessary. Depends on what's being treated. I would say if you're going to do a spine, I need an MRI before I'm going to go inject in your spine. If it's knee osteoarthritis, yeah, probably not. Though an MRI is always helpful. If you happen to have one, bring it in. If you don't, we don't necessarily need one.
We do, we need some type of imaging usually. I mean, if it's just an X-ray, we can usually go off of that or something. But we try to. We're not playing guessing game here. So we're trying to definitively determine what is causing the problem you're dealing with, and then try to treat that problem. So sometimes it requires imaging. It might be lab tests. It might be other testing, but we need to identify what the source of the problem is first. So let me ask these. These are questions we received on email, right? So question reading, are you able to treat hip OA, which is osteoarthritis? So absolutely. Osteoarthritis is one of the options we can use this treatment for. If you failed or tried other treatments and it didn't work, then absolutely. Follow-up question is, what is the procedure? Well, again, it depends on the severity of the osteoarthritis of the joint. We have to verify that it is the hip joint, but essentially we can either use the PRP, the platelet-rich plasma, or even the bone marrow, which is the stem cell treatments, depending on how severe the problem is. But essentially we're taking this orthobiologic, this blood product, and we're putting it into the area. So either indirectly into the hip joint itself. If it's really far advanced, sometimes it requires injection directly inside of the bone, not only the joint, but there's so many variables. We can't really talk about it, but essentially, yes, we can use PRP in our treatments for hip osteoarthritis. Is it covered by insurance? No. Commercial insurance, Medicare, does not cover PRP or bone marrow treatments for orthopedic type injuries.
Except for TRICARE for active duty, they would cover PRP for knee osteoarthritis and elbow osteoarthritis. So all my active duty guys and TRICARE recipients, come on down.
Yeah, I apologize for that. So some insurers will cover very specific diagnoses, but in the global scheme of things, typically they don't cover the treatments we offer here. So the other question is efficacy. Can you provide studies? So the problem with that is the studies are so all over the board. And just like we mentioned from the get-go, not all PRP is the same. Not all stem cell treatments are the same. There's a ton of studies out there that show that there's such a variance in product and what the ultimate PRP is with what product you're using. Is it a tabletop? Is it somebody that's measuring it, et cetera? So the current studies that are available they're too variable to really make a statement. But as far as our own anecdotal response, I would say it's probably 80% improvement from the treatments we provide.
So there's different kinds of medical studies. There's what's called a double-blind placebo-controlled studies. Those are the gold standard. Those are the best kind, which basically the patient doesn't know if they're getting PRP or placebo, and the doctor doesn't know if he's injecting PRP or placebo. Those studies are very few and far between. They're tough studies to fund. So I wouldn't necessarily tell you there's those kind of gold standard studies out there. There's plenty of studies showing PRP works. and there's plenty of studies showing PRP doesn't work.
Yeah.
And the first question you need to look for is what dose was injected. And most of the studies don't talk about a dose. They don't check for a dose, which is like saying Motrin doesn't work for the headache, but you don't know if I gave you 25 milligrams or 600 milligrams. So dosage matters for medications, dosage matters for PRP. That's the shortcoming of the literature. Our data is what's called prospective data. So we're taking our patients and we're tracking them over time. And that's where Dr. Farhat's comment goes. 80 to 90% of our patients are having success. That they categorize themselves as not only is their pain going down, not only is their function going up, but they are overall satisfied with their outcome at 6 months to a year.
Yeah, and then I think if you actually scrutinize those studies that show improvements and good outcomes with PRP, a lot of those studies will show that the dosage of the PRP is around 5 billion cells and up. So here in our office, we consistently get 5 billion cells and up, even up to 10 to 12 billion. So we always shoot for those high doses. So, and that's why it's important to have a good system to create high quality, high dosage PRP, because that's going to dictate your outcomes too. I've had patients come and tell me that they've had PRP before, and they're always surprised to hear that we only offer one treatment of PRP, because they've had PRP treatments where they've had 3 or 4 or 5 of a series of PRP, and they thought that was the norm. In medicine, you want to just do it once, you want to do it right. If you're going to go to a surgical procedure, you want to do it once, you want to do it right. And having that right dose makes it important. The reason why some patients get PRP multiple times is because that maybe they're not getting the right dose of PRP, and it's suboptimal dosing and suboptimal PRP, and you have to hedge your bets by doing multiple injections. So hopefully you can have that cumulative effect. But if you have that right dose at the one time, then it should work the first time all the time.
Mm-hmm. Do you want to answer any more questions? Are there any more questions?
I think that's all the time we have for now.
Okay. Running out. We got a lot of questions. Yep. Thanks everybody for writing in, for tuning in. If you want to email us, we're happy to reply by email, support@mcfrm.com, or feel free to give us a call, 248-216-1008. We do telemedicine visits as well, so we can answer questions in depth based on you and your story, just to see if you're a candidate, especially if you're coming from out of town.
All right. Thank you, guys. Good night.
Bye, everyone. Thank you.
Bye.